This is Chapter 9, Module 1, Joint Classifications and Accessory Structures. The learning objectives of this module are 1. Describe the difference between functional and structural classification of joints. 2. Describe the difference between syndesmosis, amphiarthrosis, and diarthrosis joints. 3. Describe the basic structure of a synovial joint and common accessory structures. 4. Identify the ligaments of the shoulder joint, the elbow joint, the hip joint, the knee joint, and the vertebral column.
Two classification methods are used to categorize joints. One way to categorize joints is based on function and on the amount of movement possible between two bones. There are three functional groups. The synarthrosis is an immovable joint, which can be either fibrous or cartilaginous. This type of joint may fuse over time. A synarthrosis joint includes the sutures of the skull and the gomphosis that binds the teeth to the bony sockets in the mandible and the maxilla. These are extremely strong joints and are located where movement between the bones must be prevented. The amphiarthrosis is a slightly movable joint that is either fibrous or cartilaginous. The amphiarthrosis permits more movement than the synarthroses, but it's much stronger than a freely movable joint. An example of an amphiarthrosis are at the pubic symphysis, where the articulating bones are separated by a wedge or a pad of fibrocartilage, and at a syndesmosis, where bones are connected by a ligament, for example, at the distal articulation between the tibia and the fibula. A diarthrosis, or a synarthrosis, is a freely movable joint. The diarthroses are subdivided by the movement that each joint allows. Diarthroses are usually located at the ends of long bones in the limbs. A monaxial synovial joint allows for movement in only one plane, like at the elbow and the ankle. A biaxial synovial joint allows movement in two planes, like the wrists and the ribs. And a triaxial joint allows movement in three planes, like the shoulder and the hip. The second way to classify joints is based on the anatomy of the joint, whether it is bony, fibrous, cartilaginous, or synovial. The two ways to classify joints are loosely correlated, but we will use the functional classification rather than the anatomical one. We'll spend most of the discussion on this segment on synovial joints. Synovial joints are freely movable and classified as diarthroses. A synovial joint is surrounded by a joint capsule, which is also called an articular capsule. Synovial fluid produced by cells in the joint capsule fills the joint cavity. Special articular cartilages cover the articulating surfaces. These articulating cartilages resemble hyaline cartilage but have no perichondrium surrounding them. The surfaces of the articular cartilages are slick and smooth and help to reduce friction during movement at the joint. Synovial fluid prevents two opposing articular cartilages from coming in contact with each other. If the articular cartilages are damaged, joint function usually can't continue as the bone matrix becomes exposed and the slick, smooth surface changes to a rough, abrasive surface. This abrasive surface increases friction at the joint. Synovial fluid resembles interstitial fluid with a high concentration of proteoglycans. Even in a large joint, such as the knee, the synovial fluid is normally less than 3 milliliters. The synovial fluid within a joint has three primary functions. It helps to lubricate the articular cartilages to reduce friction between the moving surfaces of the joint. It also contains nutrients for the chondrocytes of the articular cartilages. It also provides shock absorption to help cushion joints that are subjected to compression, such as when you jog or run. There are many accessory structures with synovial joints, including pads of cartilage or fat, ligaments, tendons, and bursa. Here we will look at a sagittal section of a knee joint. In many joints, like the knee, a meniscus may lie between opposing articular surfaces. A meniscus is a pad of fibrocartilage located between opposing bones within a synovial joint. The meniscus subdivides the synovial cavity and may allow for variations in the shapes of the articular surfaces. Fat pads are localized masses of adipose tissue that are covered by a layer of synovial membrane. These fat pads protect the articular cartilages. When the bones move, the fat pad fills in the spaces created as the joint cavity changes shape. Ligaments support, strengthen, and reinforce synovial joints. Ligaments join bone to bone. They're very strong. In a sprain, a ligament is stretched to the point where some of its collagen fibers are torn, but the ligament as a whole survives and is undamaged. A ligament tear will occur with more excessive force and will heal very slowly, as ligaments have no blood supply. Broken bones, on the other hand, heal more quickly because of their extensive blood supply. Tendons pass across or around a joint. Tendons extend from muscles and attach to bones. It doesn't limit the joint's range of motion, but it does help to stabilize the joint. For example, tendons of the shoulder help to brace the shoulder joint. The bursa are small, fluid-filled pockets in connective tissue. They contain synovial fluid and are lined by a synovial membrane. Bursa are found between a tendon or ligament and other tissues and prevent these structures from rubbing. They are mostly located around synovial joints, like the shoulder joint or the hip joint. If a bursa develops because of abnormal stresses, it is called an adventitious bursa. If a joint is highly mobile, then it cannot be very strong. The greater the range of motion at a joint, the weaker it becomes. A synarthrosis, which permits no movement, is the strongest type of joint. A diarthrosis is far weaker but permits a greater range of motion. When a skeletal muscle contracts and pulls on a tendon, movement of the joint occurs. The joint during movement may be stabilized by the shapes of the bone, the capsule, the ligaments, tendons, and muscles associated with it. When reinforcing structures can't protect a joint from extreme stresses, a dislocation may occur. In a dislocation, the articulating surfaces are forced out of position. This displacement can damage the articular cartilages, tear ligaments, or distort the joint capsule. A dislocation is extremely painful because of the sensitive pain receptors associated with the capsule, ligaments, and tendons. A subluxation is a partial dislocation and is less severe. People who are double jointed have joints that are weakly stabilized, and they are more likely to suffer partial or complete dislocations.
Ligaments between bones in a joint help to stabilize the joint and to prevent injuries. There are many joints or articulations between the individual bones of the spine. These articulations occur between the inferior articular process of one vertebrae and the superior articular process of the vertebrae below it. This type of joint is a gliding joint. There are also articulations between the adjacent vertebral bodies. The intervertebral discs are pads of fibrocartilage that separate the vertebral bodies. The tough outer layer is called the annulus fibrosus, and this layer attaches the disc to the vertebrae. The inner core is a gelatinous elastic substance that helps to absorb shock. As the vertebral column moves, this inner core, called the nucleus pulposus, shifts and the disc conforms to the motion. In addition to the intervertebral discs, there are 6 different intervertebral ligaments that bind the vertebrae together and help to stabilize the vertebral column. The anterior longitudinal ligament runs down the anterior surface of the spine, from the axis to the sacrum, traversing all of the vertebral bodies and the intervertebral discs. It functions to prevent hyperextension of the spine. The posterior longitudinal ligament runs down the posterior surface of the spine, from the axis to the sacrum, traversing all of the vertebral bodies and the intervertebral discs. The posterior longitudinal ligament is more narrow over the vertebral bodies and wider over the discs. It functions to prevent hyperflexion of the spine. The ligamentum flavum is a ligament that connects the lamina of the spine. This ligament is very elastic and helps to keep the posture in an upright position, as well as to help the spine resume its normal position after flexion. The interspinous ligament connects adjoining spinous processes. It functions to limit flexion of the spine. The supraspinous ligament connects the tips of the spinous processes from C7 to the sacrum. It helps to maintain the upright position of the head. The ligamentum nuchae continues from the supraspinous ligament at C7 to the skull. This ligament also helps to maintain the position of the head, especially while running. The shoulder joint is also called the glenohumeral joint. It allows more motion than any other joint and is the least stable of all the joints. It is supported by skeletal muscles, tendons, and ligaments. Between the head of the humerus and the glenoid cavity of the scapula, the shoulder joint is a ball-and-socket diarthrosis joint. The shoulder joint has several connective tissues that help to stabilize it. The glenoid labrum of the glenoid cavity is a fibrocartilage lining that extends past the bone and helps to deepen the socket of the glenoid cavity. There are 2 processes on the scapula that help to stabilize the joint. The acromion and the coracoid process are both lateral projections that are superior to the humerus. Several ligaments attach between the acromion, the coracoid, the clavicle, the glenoid cavity, and the humerus to stabilize the joint. The glenohumeral ligament attaches the glenoid cavity to the humerus. The coracohumeral ligament attaches the coracoid process to the humerus. The coracoacromial ligament attaches the coracoid process to the acromion. The coracoclavicular ligament attaches the coracoid ligament to the clavicle, and the acromioclavicular ligament attaches the acromion to the clavicle. There are also several muscles that help to stabilize the shoulder. We call these muscles the rotator cuff. They include the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. The tendons of these muscles help to stabilize the shoulder joint, while the muscles allow the shoulder to rotate. The elbow is a stable hinge joint. There are articulations involving the humerus, radius, and ulna in the elbow joint. The largest articulation at the elbow is the humero-ulnar joint, where the humerus and the ulnar bones articulate. There is limited movement at the humero-ulnar joint. A smaller articulation is at the humero-radial joint, where the humerus articulates with the radius. At this joint, the radial head pivots on the humerus. The biceps brachii muscle is attached to the radial tuberosity and controls elbow motion. The elbow has 3 ligaments, the radial collateral ligament, the annular ligament, and the ulnar collateral ligament. The radial collateral ligament connects the humerus to the radius. The ulnar collateral ligament connects the humerus to the ulna, and the annular ligament encircles the head of the radius. The hip joint is also called the coxal joint. It is a strong ball-and-socket diarthrosis. The hip joint has a wide range of motion. The head of the femur fits into the socket of the acetabulum. A fibrocartilaginous labrum extends the acetabulum to make it deeper and more stable. There are several ligaments of the hip joint, including the iliofemoral, the pubofemoral, and the ischiofemoral. The iliofemoral originates on the ilium and inserts on the anterior femur. The pubofemoral ligament originates on the pubic bone and inserts on the posterior femur. The ischiofemoral ligament originates on the ischium and inserts on the anterior femur. The knee joint is a complicated hinge joint. It functions to transfer the weight from the femur to the tibia and to allow for knee extension and flexion. There are 2 articulations of the knee joint. One articulation is between the tibia and the femur at the medial and lateral condyle. The other articulation is between the patella and the patellar surface of the femur. Several connective tissues help to stabilize the knee joint. The menisci are fibrocartilage pads at the femur-tibia articulations. The medial meniscus is between the medial condyle of the tibia and the medial condyle of the femur. The lateral meniscus is between the lateral condyle of the tibia and the lateral condyle of the femur. The menisci cushion and stabilize the joint and give lateral support to joint movement. There are 7 major supporting ligaments of the knee. The patellar ligament is anterior and the popliteal ligaments are posterior to the joint. The tibial collateral ligament is a medial ligament connecting the femur and the tibia, and the fibular collateral ligament is lateral. The anterior and posterior cruciate ligaments are inside the joint capsule. The ACL and PCL crisscross inside the joint and are named by which surface of the tibia they attach to. The anterior cruciate ligament attaches to the anterior surface of the tibia after it crisscrosses through the knee joint. The posterior cruciate ligament attaches to the posterior surface of the tibia. This ends Chapter 9, Module 1, Joint Classifications and Accessory Structures.